I am getting into a little different topic, but a very common problem that is faced by most of us. I am trying to focus on an issue which is considered as one of the serious problems which is being faced by most of the physicians who are practicing. Of course, we face the seriousness of the problem, but we try to forget what next has to be done. Next slide, please. See, basically, thrombosis as we envisage is going to be one of the commonest problems. When we looked into the records of MS Ramaya Medical College admissions as a general from all the possible specialties, including surgery, neurology, the cardiovascular surgery, etc., we could find that around 3% of the admissions are constituted by one or other episode of a thrombosis. The manifestation of thrombosis, as we look, is not a single common line. It can manifest in any of its possibility. Either it could be a myocardial infarction, or it could be a stroke, or it could be a plain deep vein thrombosis, or it could be a gangrene. So in a sense, the thrombosis could be as benign as just a swollen, painful calf muscle, to a worst scenario of a tragic sudden cardiac death because of a thrombosis in the coronary circulation. In a sense, the extent of the morbidity or an extent of the mortality or a cause of a concern depends upon where exactly or what is the site of a thrombosis. The thrombosis in situ is always pathological. Let it be post-operative, post-trauma or post-injury, we need to consider that whenever a thrombosis occurs at any site, let it be vein, let it be artery, let it be an important circulation, or let it be a non-critical circulation, we need to consider it as pathological, and we need a reasonable explanation. What I meant here is, suppose patient had a hip fracture, develops a thrombosis, you have an explanation there. Patient had hip fracture, went for a prolonged rest, non-ambulant rest, resulted in thrombosis. But on the contrary, a person who is walking, moving around, running around, develops a deep vein thrombosis, you need an explanation. Why did he develop thrombosis? Why we need to know about this is what next may happen with reference to a thrombosis. It could be lucky as long as clotting is happening in the periphery, but the same clot which happens in the periphery, dislodged from this site, moves into the pulmonary circulation where he is finished. In a sense, what we look at is a long-term management of this patient who first time manifested with a thrombosis in one of these places. Why do we need to know a cause of it? Why do we really need to know what caused a thrombosis? To tell you, the treatment may depend upon as simple as a simple folic acid supplementation, which is a line of treatment when it comes to a homocysteinemia, to a problematic continuous oral anticoagulation, which could really cause a lot of concern when we put these patients. So in a sense, it could be a very simple treatment if you know what the reason is, or you may land up with a longer problematic treatment which is essential when you know what exactly is the reason for thrombosis. We need to be clear in what is the responsible factor for thrombosis, how exactly we need to. I just spent 10 to 15 minutes of my next slide just to prevail upon how we really have to approach in making a reasonable cause, identify the cause, and try to treat as much as possible. I prevail less on the treatment aspect because the time of 20 minutes, 25 minutes can provide me only to go about how to investigate it. But subsequently, it's a pure protocol based. There are guidelines. Once you identify a X cause, this is how you need to handle it. The next slide, please. Please. Next slide. So when it comes to approaching a case, we need to approach a case of thrombosis in 3 levels. One is in a sense, basically when it comes to thrombophilia, we have 3 problems which we are encountering. One is There are certain problems in analysis of thrombophilia. As I could come across, there is definitely, we lack a lot of information with reference to thrombophilia. We know less and less about thrombophilia. If we check through what are the practical problems, how we need to evaluate a thrombophilia, most often we are not really aware how we need to go about or how to work about it. Most often what really happens in any hospital is when a patient walks in with a thrombosis, say he has a pulmonary thromboembolism or say he has a deep vein thrombosis, we treat thrombosis because acute phase is over, painful condition is over, the patient was admitted into critical care unit, has come out of the critical care unit, the acute episode is over, subsequently most of us will forget what next to be done. In a sense, acute stage of thrombosis is over, what next to be done is usually we forget because we try not to further work it up, or the patient do not come back to us asking the question that why did this clot happen, should I do something on this, because he feels the problem is over. We really have to understand that we need to analyze what is the cause of thrombophilia and we need to have adequate knowledge on that. The next is, after the acute stage is over, we need to work it up further. The next problem what we face with reference to analysis of thrombophilia is quite a few of these tests are very expensive and few are not available within the ambit. Of course, this particular problem of expensive cannot be solved so easily because most of the kits or most of the methods that are available when we are trying to analyze the thrombophilia are very expensive. But as previous speaker, Dr. Rajan was trying to highlight, if you look back forward from the time you identify a thrombosis, if you go for a preventive measures, normally the cost that you are going to incur because of acute emergency admissions, including the cost of life, including the morbidity, could be largely prevented. But we need to calculate, that's why if you really calculate it, the cost effectiveness of these tests are not really very high. Second problem is the availability. The basic problem is you ask for few tests, invariably comes back to say it's not done here, it's not done there. But anyway, I think we are trying to circumvent this possibility of not availability because most of these tests are now made very much available within the premises of our center. We do have an exclusive thrombosis workup. The entire thrombosis workup could be done. But still, the availability becomes a problem because this cannot be done in every day-to-day regular laboratories. Few tests need to be done at site. In a sense, samples need to be analyzed within few hours. And sample needs to be analyzed much quickly. So that makes a problem that sample cannot be brought into one central location or can be done afterwards. So certain of the tests which need to be done early or faster cannot be handed over to some other place and done. There are certain of the problems that we need to analyze the thrombophilia. Next slide, please. When it comes to thrombophilia, we categorize them as certain of the causes which are reversible, which you can prevent, alter, or change by interfering, like cigarette smoking, hypertension, diabetes mellitus, if a good control of that, continuous persisting left ventricular failure, oral contraceptives, possibility of thrombosis. There are reversible causes. You can identify these causes and you can prevent or reduce it. Similarly, certain of the conditions which can lead for venous thrombosis, they all could be corrected and handled as and when it is there. In a sense, like obesity, certain of these conditions can be managed when they are there because they are absolutely reversible. Comes next slide. See, there are certain conditions which are not absolutely reversible, like atherosclerosis. Once a plaque has happened, the plaque remains there. And hypertriglyceridemia, you can control to a certain extent, but we still sometimes have that can we effectively do a lot. A positive family history of thrombosis, the lipoprotein A, polycythemia, hyperviscosity syndrome, certain of leukostasis syndrome of congenital causes, where changes are not possible because you need to either go for a bone marrow transplant or something of that kind. In addition to that, you have certain of the acquired defects like antiphospholipid antibody syndrome, activated protein C resistance are factor V valence, sticky platelets, various protein defects like proteinase defect, protein C deficiency, antithrombin deficiency, heparin cofactor deficiencies, plasminogen deficiency, TPA deficiencies. So we have quite a long list, including another common one called homocysteinemia, it's a metabolic disease, where there is an increased tendency to clot or thrombose, which we need to identify, and these are the things which is, since they are not reversible, need to be managed for a long term. The next slide. All of us are very clear at this point that the blood, as long as it's flowing smoothly in the circulatory system, will never clot. It has a perfect balance, a perfect equilibrium it maintains between a pushing procoagulant activity and an antagonizing anticoagulant activity. The next slide, please. Wherein you can see that whenever there is a problem, either like certain of the factors which can promote the activity, clotting, or certain of the factors tries to bring down the clotting activity. Based on that, where they interfere, either by gaining the function or by losing the function, we may land up in thrombosis. To give an example, if there is a decreased natural anticoagulant like protein C, proteinase, and antithrombin 3, when either the quantities have come down or their functional activity has come down, they result in thrombosis. Similarly, when the inhibitors activities or any other of these activities are increased, they may end up in, that's what we call as gain of functions, can result in thrombosis. So there are a lot of variations that we can see, but most of these, in the end of the day, leads to a thrombosis. The next slide, please. See, this is a long list. I think I don't like to go through this because this list we have given in the print. And there are so many factors when they are defective can result in thrombosis. The next slide. This is just to explain a simple, easy way to understand how protein C and proteinase can interfere in thrombosis. See, if you look at it, whenever there is a activation of a thrombin, sticking with thrombomodulin, the protein C gets activated. This, in the cascade of the pathway of the clotting, factor V and factor VIII, which gets activated, this is in turn inhibited by the activated protein C proteinase complex. How the defect can happen is, one is if the protein C itself is defective. Second is if the activated protein C is not able to digest the factor 5A, which is mutant and not able to be digested and cleared by the activated protein C, which is what we call as activated protein C resistance. And similarly, if there is a defect in the activation by the thrombin-thrombomodulin complex, this in turn takes the same pathway into task. That results once again in thrombosis. In essence, if you look at the multiple cascade, I still wonder why the nature has evolved so much of multiple cascade in a single entity of a thrombosis, but certainly this complexity may be necessary to have a continuous ongoing equilibrium balance that has to be maintained, but defect in any of these areas can result in the end of the day a sort of a procoagulant state. Probably because of this redundancy, even though there are minor defects, which is much more commoner than what literally clinically manifest, still we don't manifest so much as we expect with reference to the number of mutations that is possible. The next slide. This is what the APC resistance, that is activated protein C resistance we talk about. The APC, because of the mutation in the factor Via in the substitution in these areas, results in the factor Via being or cannot be inactivated. These are three possible mutations, as a consequence of which the factor Via cannot be disintegrated by activated protein C. The next slide. How do we test this actually? How exactly we can verify this? Normally we do a test based on the PTT. So if you look at, first you look for the screening test of the protein C resistance, And one thing is that you need to be very clear that the patient shouldn't have a lupus anticoagulant. In that event, you need to work it up further, because lupus anticoagulant itself could be a responsible factor for the thrombosis. So if it is positive for lupus anticoagulant, go for further dilution and so on. So if you are suspecting the factor V needle or APCR, then the same experiment is used by using factor V deficient plasma. If it is abnormal, then it suggests a possibility of activated protein C deficiency. But when you are able to work with this, if there is not much of inhibition, then it suggests there is no activated protein C resistance. Then you need to analyze for other possible deficiencies. The next slide. Similarly, the other commonest metabolic defect that what we see is homocysteinemia. This is supposed to be one of the commonest metabolic disorder, wherein the homocysteine level which is produced is increased. The various mechanism, the homocysteine is supposed to produce the thrombosis. Either it promotes the endothelial cell desquamation, or by oxidizing low density lipoproteins, it is supposed to promote the monocyte adhesion to endothelium, or it can promote thrombin generation by the vessel wall and enhance the platelet turnover. There are 3-4 different mechanisms which has been explained how a homocysteine can promote the thrombosis. By normally, in a nutshell, what it really does is, at the interface between the endothelium and the clotting factor, it promotes the inhibition which is there on the clotting factor at the endothelial level, promoting further our procoagulant activity. And most often in homocysteinemia, what we see is a thrombosis in arterioles and less commonly in the veins. Next slide. This is the normal defect what you see with reference to homocysteine, wherein there is a defect either in methionine synthesis or MTHFR, or sometime in cysteine beta synthetase deficiency. Most commonest deficiency what you see is in methionine synthase deficiency, wherein homocysteine is either not translated into methionine or into cysteine, resulting in the excessive accumulation of homocysteine. What we try to do here is, if you see it, there is an active role played both by B12 as well as the tetrahydrofolate. So if you increase the tetrahydrofolate concentration as well as B12 concentration, you can promote as much of homocysteine either to be translated to methionine, and adding B6, you can promote it moving towards cysteine and cysteine. So as a consequence of which, you can bring down the homocysteine level. And what we try to use here is to manipulate within the dietetics, adding certain vitamins which can promote the conversion of homocysteine away from to methionine or cysteine values. The next slide. The other commonest but an acquired defect is an antiphospholipid antibody syndrome. There are several criteria to make a diagnosis. The most common is what we use, and the most updated criteria is usually the patient should have one or more episodes of vascular thrombosis. Either it could be arterial, venous, or combination of arterial and venous, either major or minor vessels, but one need to confirm a thrombosis. This is one of the problems that we face with reference to APLA syndrome. In a sense, we are talking of a preventive measures, but most commonly, we need to have a thrombosis before you make a diagnosis. Other alternative criteria that we make is a recurrent pregnancy loss, which is one of the common clinical manifestation you see with antiphospholipid antibody syndrome. There are predefined criteria when to consider a recurrent abortion into falling into criteria of APL syndrome. In addition to these two clinical criteria, one must prove the presence of antiphospholipid antibody, either as an elevated anticardiolipin antibody or a positive lupus anticoagulant. This is the normal way how we try to work it out. When the patient sera is either tested for APTT, if APTT is abnormal, mix it with the normal plasma. So if there are antibody against certain of the factors, normally they'll go for a correction because you're trying to nullify them as much as possible. So once this correct with the normal mixing experiments, usually you think in terms of a deficiency of the factors and you further analyze for any possible factor deficiency. Next, what you do is to correct with phospholipid. Mix it with phospholipids. If there is an anti-phospholipid antibody, normally they neutralizes, as a result of which there is a correction of the APTT which is abnormal. Then we consider it as the positive test for lupus anticoagulant. If it is negative, we need to work up for other coagulopathy conditions. Otherwise, even if the APTT is sometimes normal, you are still considering the possibility of an anti-phospholipid antibody syndrome. Check with DRVT. Then if it is normal, it is less likely to have lupus anticoagulant. There further testing is discontinued. But if it is prolonged, then once again go for the mixing experiments, as it is suggested here, with phospholipids. If it is going to be rectified, then we are thinking it in terms of a definite confirmation test for lupus anticoagulant. APTT is normal, no other possibility of an APLS syndrome, we can discontinue here in further working up with reference to lupus anticoagulant. Next slide, please. The question that remains for us is that, because we do see most of the textbook, especially the older textbook, saying that thrombosis is not a common problem in Indian setting. We always have been taught to us DVT is not commonly seen in Indian patients. Probably, I still remember the word from Dr. Beck's slides which he presented across. He said, a disease becomes rare if we rarely think the possibility of that disease. In a sense, if we think if this disease is rare and we try not to think about that disease, obviously the disease is going to become more and more rarer because we are not likely to look for that particular disease. If you look into the various studies which we can see, it really highlights, these are just a collection of the studies published from India. Only I have picked up the possible highlighting studies, which clearly says that approximately around 3 to 5% of the admissions in most of the hospitals do have venous or an arterial thrombosis. And there are certain of the studies where they have tried to analyze the possible causes for thrombosis. From our own publication, of course, where we didn't do with reference to homocysteinemia and factor V laden, we could find that in our population, either the antithrombin deficiency or anti-phospholipid antibody syndrome was the most commonest cause for the venous thrombosis. Next in line was protein C and protein S. Similarly, there are studies published across the different places from north and south. We do see that the anti-phospholipid antibody syndrome, next is the factor V laden, which makes the next commonest, and then we have protein C, protein S deficiency, and also the homocysteinemia also rank as one of the commonest cause for the deficiency. For the thrombophilia. This just puts us to say that whenever we try to evaluate a patient of thrombophilia, best approach would be is to look for the common possibilities. The first is to look for a possible screening of anti-phospholipid antibody syndrome, especially in a set of patients who don't have a family history of thrombosis. If a first person to have a thrombosis, no family history or no antecedent history of thrombosis in family, while taking this, we need to cover every possibility like stroke, acute myocardial infarction in young, any other possible cardiovascular events, recurrent pregnancy loss in the family. All these histories, none of them are there. Possibility of an acquired defect should be first considered. If that is negative, then you need to work up on the other possibilities. If it is an arterial, look for homocysteine along with the cholesterol and lipid profile and other classical traditionally worked up possibility of cause for arterial thrombosis. Subsequently, one can work for the hereditary or familial. So if you plan it out in such a way that you can work it on step by step, that can certainly reduce the burden of economics what we were worried about in the very beginning of the discussion. In a sense, if you plan first to look for the common possibility based on the clinical input, subsequently look for the uncommon possibility, one can work on more economical to get into the root cause of the diagnosis. In a nutshell, what I would like to convey across is that thrombophilia is not a rare disorder in India. It's wrong from our perspective to think that we don't thrombose. In a sense, we do have a thromboid tendency in our population. We need to identify the exact possibility whenever and wherever we come across with a thrombosis. Making a diagnosis of a deep vein thrombosis, arterial venous thrombosis, arterial thrombosis, or a myocardial infarction in any no risk factor seen, or as any venous occlusion in any of the location is not a complete diagnosis. We are just talking about a symptom, a fever, and we are almost at a point of saying that the patient had a fever, what is the cause for fever? You need almost to work in the same setting. The patient has thrombosis, what is the causative factor? So it is, thrombosis cannot be taken as a conclusive diagnosis. The cause for thrombosis as available from Indian literature one can go is APL or anti-APCR, homocysteinemia, protein C, protein S, and antithrombin deficiency. This is the descending order in which we do see with reference to Indian population. It will differ from North Indian, South Indian, East and West, but of course we really require a large-scale study to understand what is the real commonest cause for thrombosis with reference to the Indian population. Once we screen the index case, it may almost be necessary to screen the family so that family members are warned about a possible catastrophic thrombosis which can be prevented as and when required. Thank you very much.